my name's Tim Vizard, as I said, from the ONS. In terms of the structure for today, what we want to cover is first to give you an overview of what the aims of the survey was, so quite a broad overview of what we aim to do in the survey for the 2017 Mental Health of Children and Young People survey, and then go into a bit more detail throughout the remaining sessions to explain how we measured mental disorders in children, which Tamsin will talk you through how we achieved that. Katharine Sadler will then talk through how we designed the survey, all the thoughts that went in around the design stage to get the survey developed. We thought you'd like a tea and coffee break at that point, so we'll have one of those. And then in the second part of our presentation, Salah will talk through the sampling and weighting of the survey design. And then I'll come back and have a chat about how we actually collected the data from the people who we were interested in, and that was the children and young people aged 2 to 19 in England. And then we'll talk you through the key findings from the survey and end on talking about what the next steps are and take some questions and answers. We've put questions and answers at the end of the session, but I think we're happy to receive questions at the end of each session. So please feel free to do that as we finish each session. Come on in. So, aims of the survey. So I won't introduce myself again, but for those who just joined, I'm Tim Vizard from the ONS. And you're here to talk, to listen about the Mental Health of Children and Young People Survey 2017. So this was the first official estimates of mental health in children and young people since 2004. So that's over 13 years since the last study was conducted of this nature. So if you're lucky enough to be 30 or younger in this room, then you would have been young enough to be sampled in the last survey as a child or young person. So that kind of emphasises the fact that these data are very important to be repeated again. The survey, the 2017 survey and the previous surveys of this series applied rigorous, detailed and consistent methods to assess a range of different types of mental disorders among children and young people. And we used two classification systems here, the International Classification of Disease, ICD-10, and the American equivalent, which is the Diagnostic and Statistical Manual of Mental Disorders, DSM-5, but it's predominantly ICD-10. Tamsin will go into a lot more detail about this than I will, so as she's the expert in this area. And all the data we collected were rated by clinically trained raters, so it was all reviewed by people who had the expertise in order to make judgments around the mental health of the people in our survey. I mentioned that we conducted previous studies, so the first time this study was ever conducted was back in 1999, and that was the mental health of children and adolescents in Great Britain. That included 5 to 15-year-olds in Great Britain. There was a follow-up then conducted in 2002, which looked after children in local authority care, and that looked in England only. And then in 2004, there was a second cross-sectional survey that was conducted in the series. That looked at the mental health of children and young people in Great Britain again. You're probably sensing the theme. But that then looked at 5 to 16-year-olds, so it included 16-year-olds for the first time in the survey. And then there was a follow-up again in 2007 that looked at those children who took part before, 3 years on, to look at their outcomes at that point. So the 2017 survey that we've conducted, it covered 2 to 19-year-olds in England. So the coverage of England was different to previous surveys that had covered Great Britain. I won't go into the reasons for that, but essentially it was funded by the Department of Health and Social Care and NHS Digital, who both have a remit for England, and there were other kind of agreements in place for other GB countries to cover that surveys differently. The inclusion of 2 to 4-year-olds and 17 to 19-year-olds for the first time was interesting. For 2 to 4-year-olds, it gave us a rare insight into the mental health of children and young people prior to entering the education system in that very early stage of development in children of that age. We also included 17 to 19-year-olds for the first time, which kind of responded to a broadening definition of adolescence and the fact that this age group, obviously, there's a lot of interest in their mental health and important to collect information on this group. We collected robust data on a range of topics related to the mental health of children and young people. And we set out to estimate the proportion of children and young people in England living with a mental disorder, but also the types of the mental disorders experienced by those children. And also, because this was a part of a series that had been conducted before, we set out to produce trends in disorders through comparisons with previous surveys in the series. So therefore, it was important that we kept that robust and consistent methodology with the previous surveys. In addition to that, we set out to compare the circumstances of children and young people with mental disorders compared to the circumstances of those children without mental disorders to do some comparisons. And the final two things were kind of service-driven. So we looked at to improve our understanding of the state of children and young people's mental health, but also looked to inform the design of mental health services of children and young people in the future. So Carl's introduced the survey team, but I'll just give a little bit more background to our roles on the survey, just to give you an idea. So NHS Digital were the commissioning department. So NHS Digital are essentially the data owners of the survey. When the results were published, it was on their website. So we're talking as with NHS Digital survey in mind here. NatCen, social research, so Katharine Sadler, she led our consortium of researchers on the survey, and NatCen's kind of main responsibilities, I mean, we ended up doing lots and lots of things, so this doesn't preclude all of that, but it was agreeing the survey content, looking at the respondent materials to engage with the people who are trying to talk to, conducting the fieldwork, processing all the data, and also writing the report at the end. Within ONS, we were responsible for the sample design and the weighting of the survey data. We were also responsible for the programming of the actual questionnaire instrument and conducting the fieldwork and co-authoring the report with NatCen. And finally, but most certainly not least, Youth in Mind's responsibility was providing the expertise and this specifically overseeing the clinical assessment of children's mental health. That was led by Professor Robert Goodman, and alongside Professor Tamsin Ford, who's with us today, and Dr. Anna Goodman as well was involved in those stages as well. So I'd like to give kind of a general overview of how we designed the survey, and we'll delve into a bit more detail then in the later sessions. But our sample design set out to interview 18,029 children and young people in England. Well, they were asked to take part in the survey. I say we set out to interview that many. Obviously, we're realistic and know that response rates means that's not possible. So our aim was to achieve 9,500 interviews, and we issued a sample of 18,029 to achieve that. Our sample frame was the NHS patient register, and that provided us with a person-level sampling frame, which was really good because it then provided us a frame that we could direct sample children based on their age. And we also knew the names of the children as well, which made it a lot easier to make contact with those households. And another thing there is I've put on there, this covered England only, so just to emphasise that. Then in terms of our questionnaire design, well, we developed our questionnaire through consultation with experts and tested it in a large-scale pilot. And I believe Katharine will go into a bit more detail about the consultation later on. Great, so I won't say anything more about that. And the survey set out to ask about the mental disorders experienced by children and young people, but we also looked at a range of other topics related to the health and well-being of children as well. And we consulted on users of how best to capture that information. And as I mentioned before, clinical rating of the data took place to identify the presence of mental disorders. In terms of the fieldwork and then the weighting, we set out to achieve 9,500 interviews. We actually obtained information on 9,117 children and young people, and that was collected from multiple informants. It was either parents and also children and teachers in certain circumstances, and we'll talk about how different age groups had different types of interviews later on in this session. And the data was rated to be representative of all 2 to 19-year-olds in England, and also accounted for those who did not take part in the survey, and Salah will talk you through how we achieved that on the survey. Finally, hopefully you've all seen the report that was published in November last year, but if not, have a look at the NHS Digital website. That is the shortest URL I could find. It does work, but it's still a bit of a mouthful. But we published a summary of the key findings, which, as you'd expect, is the one that most people would use. It gives a really good overview of what the survey conducted and what it found. For those interested in the more technical details, we then published 9 topic reports looking at the different types of disorders experienced by children and young people, then also looking at the behaviours and lifestyles of those children, the presence of multiple conditions and other factors as well. So there's a lot of detailed information on NHS Digital's website. And alongside that, we published Excel tables, which gave users the ability to have a more in-depth look at the data that we had collected. And finally, there was a survey design and methods report. So if you want to learn more about any of the things we're talking about today in a bit more detail, there's a technical report on the website that goes into that level of detail, and lots of appendices. To kind of emphasize what the survey was, it was an official statistic. So as an official statistic, it complied with the UK Statistics Authority's Code of Practice into official statistics. But it's important to say that for the 5 to 19-year-olds, these were branded as official statistics. But for the 2 to 4-year-olds, as this was the first time we captured data for this age group, this group were the estimates for this group were experimental statistics. Essentially, it was just to inform users that they are in development, and obviously we were engaging with users on those results, but they were had the experimental statistic badge for those estimates. So ask of a talk or question here, unless people want to answer this question, but what is mental health? And essentially it means a lot of different things to different people. And that was one of the challenges on this survey, to be really clear about what we were trying to capture. So this kind of slide here shows all the different words that a group of millennials in a study that was conducted in the United States, a university in the USA, not particularly scientific, but I thought it was really nice to show kind of the various words that people associate with their mental health. And words such as the bigger words such as depression and anxiety being quite large, but there's lots of different words on there as well. And I think it showed us how mental health means different things to different people. So it's important to be clear what we were capturing in this survey, which is mental disorders, and also to draw a distinction about what we mean by mental disorders and mental health compared to other terms as well. And I think often the word mental health and mental well-being are used quite interchangeably, but are not necessarily the same thing. And there's a report done by Dame Sally Davis, the Chief Medical Officer, that said it can't be assumed that mental illness, that's the presence of a mental disorder, simply represents the absence or opposite of mental well-being. So it's quite being clear here what we were looking at, which was mental disorders. As I mentioned before, our survey assessed mental disorders in children and young people, and we didn't just screen for general mental health problems, but we applied operational diagnostic criteria. And I mentioned those that we've used already, ICD-10 and DSM-5. And my final slide here is just to talk about how complex mental disorders are, which will set Tamsin up then to talk about how complex they are. But there was an interesting piece of research done by some academics here, the reference on the bottom here, to say that classification systems such as ICD and DSM consider mental disorders to be self-contained and distinct from one another. However, mental disorders are complex combinations of psychological problems that have overlapping characteristics. And additionally, each disorder does not have its own clear-cut cause, but it said mental health issues generally occur as a result of interactions between multiple biological, behavioural, psychosocial and cultural factors.
So, I'm a child psychiatrist by background, and I'm unusual for an academic in that I did all my training. I worked for the NHS for nearly a decade, and then I went back and did a PhD. And actually, when I did my PhD, it was on the very first survey. So I was one of the clinical raters on the 99 survey, and I've been involved in pretty much every single one of them since. We thought it'd be fun if we actually did some clinical ratings. So you're going to have to wake up in a minute, just giving you some warning, because I'm going to ask you some questions and we'll rate a couple of cases live. So the measure we used was developed for the 99 survey, and it's been used in improved form. Robert Goodman, who designed it, is a perfectionist, and so he's constantly adding additional modules for things, because it was done at a canter for 1999. So DORBA stands for the Development and Wellbeing, and it's very good because it's broad. It covers most of the common child mental health problems, and I'll give you a rundown of just the number that we organised in the technical report. There's a really useful table where you can see what was studied in the different surveys that have been carried out. It's validated right down to 2 and up to 18. And in fact, some studies of adult mental health have used the kind of older teenage version, and it seems to work okay as long as you narrow down on the disorders that adults commonly have. You can have separation anxiety disorder in your late teens, but it's unlikely. You don't meet many toddlers with anorexia, so there are steering ways through it so that you focus down on what you need to. It's efficient. It uses skip rules. So that this was a single phase study. Every single person got the full diagnostic assessment, but they were asked about 4 or 5 questions in relation to each disorder, and if the answer to all of those was negative, then you went on to the next module. The other thing that added to that was the strengths and difficulties questionnaire was completed before you went into the diagnostic module. This is a very common dimensional measure of child mental health. Those who work in relation to children will no doubt have heard of it. And where there was an indication that there was a problem on that might force you through, particularly for the emotional problems, that might force you through some of the questions that you were screening negative on. So there were lots of ways to pick up children who were struggling. The other thing is it combines 2 ways of asking questions. So if you ask very direct questions with yes, no answers, then you get very, very reliable information. But it might not be valid, because you've got no way of telling whether the person answering the question has understood what you think. So where there's a problem area, the Dorber then pulls back and asks semi-structured information, series of probes, so it can still be administered by lay interviewers who are much cheaper than mental health practitioners. They're also much more reliable because you can train them to do the interview, and they don't go off in their clinical practice thinking, oh, I don't need to stick to this schedule because, I'm a clinician, I know what I'm doing. So lay interviewers, actually, there is research evidence showing that lay interviewers are better than clinicians because they do what they're meant to do. But you then have some qualitative information. So a lovely example of where we would have got it very wrong if we just stuck with the direct questioning was a child who came up as looking like they had obsessive compulsive disorder. So they were reported to have compulsive behaviour, happened every day for an hour. It had gone on for more than 2 weeks. It was causing problems in the family. The mother found it really difficult to deal with. And then the qualitative information said this lad was playing football in the house. Now, I don't think he needed a psychiatrist. He needed a park and a football team. So the mother had misunderstood what we were asking about when we asked about a compulsion. And it is really hard to get across if you haven't come across it. It's a really complex idea. So had we not been able to see this qualitative information, that child would have been assigned as having a mental health disorder when they didn't have one. So we increased validity by using multiple informants as well. Many people who work with adults say, why on earth would you do that? Because you then make life very complicated. But that's what we do in the clinic. We never just take one person's word for it if you work with children. I don't think you can assess a child properly unless you have spoken to the child themselves, however little they are. You've spoken to the parent or parents, and you've phoned school to find out what's going on there, perhaps even gone into school. So why should we do it differently for a survey? Because all of those people have different information, and actually, teachers are fabulous at telling you about behaviour and concentration because they see a wide range of children. Parents know their own child's behaviour, but they don't have that frame of reference that a teacher does. And children know what's going on in their minds, so they're much better at reporting their emotional symptoms than the adults around them. So if you only have one of those, you are going to miss some things. So multiple informants makes the data that you've got more valid and more clinically relevant. And we were answering the question for government, how many children out there have clinically relevant problems? But then you hit a problem in that your informants are all badly behaved and won't necessarily agree with each other. So what do you do with that? And in previous epidemiological studies, some people have gone with what's called the or rule. So if anybody mentions anything, I'll believe it's there. And other people have gone with the and rule, which is I'll only accept something if all 3 informants say it's there. Now, that's not what happens in the clinic. And I'm talking to a room full of methodologists. You'll immediately see the problem if you're measuring prevalence, if you're making rules about symptoms. It's just not real life. So the other thing the DORBA allowed was the clinical rating was about putting the informant's data together in the same way that you would in the clinic. So if I saw a family and the parents said, I'm really worried, they've stopped going out, they're not seeing their friends, they're grumpy, they just stay in their room all the time, and the youngster was sort of sitting there saying, I'm fine, I'm fine. You know, I wouldn't believe the young person, I would weigh the parents' information. But equally, there are other times where it's the other way around, or the teacher, you know, it's a very complicated way that you make a clinical judgment, and it's not something you can write rules about. So the idea of the DORBA was trying to get back as closely as possible to that clinical situation. And if you want more detail about this work was led by Stefan Kolishaw. In fact, Katharine and I were talking about it earlier. I was forgetting I'd referenced it in this talk, where we put the data from the 2004 survey and 99 survey together, and both of them were followed up 3 years later. And you can see how each informant is important, but they pick up different things, just if you're interested in going further into it. We needed the teacher data. Children's job is to go to school. And if you don't know how children are functioning in school, then there's a big chunk of their life that you don't understand about. I think others will talk about this in more detail, but where the family agreed, we sent an email with the teacher's name and address, and tried to get them to fill it in online, and that was really difficult. They didn't do it, which really surprised us. Actually, paper worked better. So what did we measure? You'll see some statistics on any disorder, and that was all of them grouped together. And in fact, quite a large proportion had more than one disorder. And if you have more than one disorder, you have more than one disorder's worth of impairment. So, you know, we picked up quite a lot of children who are really struggling. That was divided into emotional disorder, broadly speaking, anxiety and depression. Behavioural disorders, of which there are two main types. There's one called oppositional defiant disorder. This is not just the terrible twos, as I spent a lot of time telling the press, and I'm sure you did, at the launch. It was the thing they really picked up on. This is children whose behaviour is so reactive and difficult that it really impacts family life, and then it impacts their development. It's much commoner in younger children. And then in the older children, you get what ICD-10 calls conduct disorder, but that is a pattern of severe norm-breaking behaviour that goes on for 6 months or more, and again is getting in the way of the child's function. Now, we could talk for an hour about the philosophy of having a psychiatric diagnosis, and I'm deliberately using language which is a bit provocative, called conduct disorder. But actually, having a diagnosis of conduct disorder in childhood in Dunedin, the Dunedin cohort predicted to every single adult mental health condition there is, including anxiety, depression, and psychosis. And their social and educational outcomes are really poor. So I think we do need to pick these children up. I think the label becomes pejorative because they are difficult children to be around, but actually we are doing them a massive disservice if we don't think about how many of them there are and how we might support them. Then we've got hyperactivity, or ADHD, because the government statistics are the WHO ICD-10. We measured hyperkinetic disorder, which simplistically speaking is basically severe ADHD. The American concept is a little bit broader. But one of the advantages of the DORBA is that it allows the clinical raters to assign not otherwise specified disorders. Now, as Tim alluded to, our classification systems are the best we have at the moment, but they're not perfect. And about 20% of the children who have diagnoses in all our previous surveys, and I don't think it's different in this one, have what is permitted in these classifications, which is not otherwise specified disorders. So these are children who have clinically relevant problems, but they don't quite fit the diagnostic criteria, which when you'll have a look at them later, they're like a recipe, and actually they're quite pedantic. And it seems silly to say this child hasn't got a problem because they've been depressed for 10 days, not 2 days, 2 weeks, or they are missing one symptom of oppositionality or whatever, but they've still got significant impairment. And then finally, there was a hodgepodge of less common disorders. So autism spectrum, tic disorders, eating disorders, both anorexia and bulimia, which were grouped together because actually, although this was a big survey, at a population level, we weren't ever going to pick up very many of them. So just to unpack the anxiety disorders, to give you an idea of how complex this data is, that is the list, which I won't read for you, but we will make the slides available. There were all those different types of anxiety disorder, and body dysmorphic disorder is in bright red because it's the first time that we studied it. It's believed to be becoming more prevalent, and it was one of the conditions where we referred quite heavily to DSM-5. So the structured bit of the DORBA just asks questions to fill in the yes/no answers you need to meet all the diagnostic criteria. It really is not coming at it from any theory. It's not rocket science. It's if ICD says you need this, we'll ask these questions to see if you've got it. So I think I've talked to you about this. Just to add a bit of data, which is that when we tested two of us, it was myself and someone called Helen Simmons, who's now a consultant in Richmond, we rated independently 500 cases and got reasonable reliability, very high reliability for ADHD and for conduct disorder, less good at the individual diagnostic level for the emotional disorders, but it's partly because of all these children who don't quite fit. Okay, so let's get that up. And I think let's look at Woody, because he's more interesting. Although I do feel very sorry for him. So when we were rating, the first thing I would do, just to check the data, is to look at this screen. So we here have a 14-year-old male, and everybody's saying he's 14 and everybody's saying he's male. So that's reassuring. Just because, you know, those of you who are researchers, error creeps in at every possible stage. Then down here on your left, you have the list of all the different disorders. And then you've got what his mum said in terms of symptoms and how they're getting in the way of what he can do, his teacher and himself. And then based on all the other surveys we've done, the computer gives a prediction of what it thinks is going on. And where there are 3 pluses, about 50% of them will meet diagnostic criteria, maybe a bit more. 2 pluses, less so, and by the time you get down to 2 minuses, it's like, you know, 99.9% of them are absolutely fine. So, pick a disorder, shout out. What disorder shall we look through? Hyperactivity. Okay. So, if you go to the top, click on ADHD. And this is what comes up. So if you want to see what that means, that's a hyperlink. If you want to double check the criteria, diagnostic criteria, although we all were issued ICD and DSM-5 because there are various different versions, so to make sure quality control, we're all rating to the same one. But again, you can click on those if you just want to have a play. So this is the screening question. Are there any concerns? And his mum says yes. We don't ask youngsters very much about ADHD because even in adulthood, people aren't very good at telling you that they struggle to concentrate because you only have experience of your own mind. I think the older teenagers and young adults will sometimes say, you know, it's always been a nightmare to do homework. I can't read for pleasure. Don't be fooled about computers. They're terribly, terribly engaging. You don't need much ability to sustain attention. But what we do ask the young people is, are people on your case? Because they do know that. And you can see Woody is saying that his parents complain about him, his teacher complains about him, and he thinks he struggles to concentrate. And he is 14. Then these are the core symptoms of ADHD, so overactivity, impulsiveness, and attention. And I won't go into the diagnostic criteria, but just to give you a sense, you need 6 from these 2 columns, which he does easily. He's got virtually all of them. A teacher who says that's time on task that they're enjoying, and this is a 14-year-old who struggles to sustain his attention for 4 minutes. That is not the normal range. That's really quite impaired. And you can see, again, he's got more than the 6 symptoms that you need. It's very telling that he thinks everybody's complaining about him, and the parents also saying that the teacher's complaining to her, which is quite the age of onset needs to be before the age of 12 for DSM-5, before the age of 7 for ICD. I can get really quite boring on the differences between them, and I won't. And then you need to have impact. Now, there's an interesting difference between ICD and DSM in that ICD you need symptoms in more than one place, and DSM you need impact. But the basic premise of ADHD is that this is a condition that the child struggles across the board with their levels of activity, their impulsiveness, and their ability to concentrate. And then let's see what the qualitative data says. So his teacher has said, I'll read it for you in case it's too small, Woodrow is potentially an able boy, but he is an underachiever because he can't sit still and get on with his work for more than a few minutes. He's forever fidgeting and finding any excuse to wander about the classroom. Even if I stand over him and insist on him staying put, he's usually incapable of persisting with whatever task I've set him for more than a couple of minutes. Bear in mind, this is a lad who's supposed to be 14. That sounds much more like a much younger boy. The least thing will distract him. Even when he's really interested in what we're doing, he still can't do it. So, I mean, this is deliberately made very clear. But that's the nature of the qualitative information. And then to assign a diagnosis, let's do ICD. When we were rating, the default on all these screens is no, and you have to actively put in when you think. But when we were rating, and before we gave the data back to Katharine and Tim, who I don't think have ever seen this process either, this is what we would do. And then behind that is an SPSS file, which you can just download from the site, and that's what comes winging back to you. So it's a really, really good system. How are we doing for time? We've got time to do one more? Shall we do a... Should we do a 2 to 4 year old? So we've got, because the child is only 4, whereas in the clinic I would chat to any child, although for a very tiny child being taken away from parents might be overwhelming, but I would make an attempt to at least sit down and engage with them. For research purposes, children don't give you terribly reliable information. They'll tell you exactly how they feel right now, this minute, but they're not that good on yesterday or, over time, which is why we only interview children from the age of 11 up. What disorder would you like me to show you the screens for?
Anxiety.
Okay. Shall we look at separation anxiety? So that's quite a tedious one because she hasn't got anything. Okay, let's go in for Bill then, who is a little bit sexist that the boys are the ones with the problems, both cases. Did I click on? Here we go. So Bill is 3. And as you can see, he looks like he's got more problems. So let's look at separation anxiety. So mum is worried. There's a preschool professional reporting in this particular child who says that he's distressed There's no problems getting into school, but he gets distressed. She wonders about impact on family life and on friendships, and an impact on carer behaviour. And let's see what the preschool professional says. He's a real worrier. If you suggest some new activity to him, you can see that he gets anxious straight away about exactly how he should do it and whether it will be good enough. He is nervous speaking up in front of others. He worries a lot about his mum. She collects him every day, and a few times he hasn't been there on time, and it's been really difficult to stop him crying and panicking. He's convinced that something terrible has happened to her, and he'll not accept any reassurance. Now, the getting upset for a child of 3 is not atypical. You start making a diagnosis when it's the extreme. So say this was a description of a 7-year-old, that kind of behaviour absolutely would be abnormal. Certainly if it was a teenager. For a 3-year-old, it's a bit on the cusp. It sounds, the nursery nurses report suggests to me that this is an anxious chap, but I'm not necessarily thinking this is a clinical level of problem at this point. Every now and then he goes through a period of refusing to stay here when his mum brings him in the morning. But we all work hard to make a fuss of him when he first arrives, and generally he lets his mother escape without protesting too much. Some days he looks really miserable and it's hard to interest him in anything. So the trouble separating is not such an issue. It's the fact that he doesn't seem to recover afterwards. I know my own kids at that age, it was awful trying to get away from them. And I'd look through the window the minute they couldn't see me, they were absolutely fine. Okay. So he's definitely, an anxious soul. Let's go back into it this way then. And we'll just see what his mum says and then finish. Okay, so we're looking at separation anxiety disorder. But actually what his mum's saying is he worries continually. He doesn't want to go to school, so as well as a struggle leaving him, so the nursery nurse is thinking this is not that unusual, but mum is struggling to get him there. He's afraid of sleeping alone. He sleeps with or checks with his attachment figure at night. He's afraid of sleeping in a strange place. He's afraid of being in a room alone. Now, at that point, most 3-year-olds will tolerate their parent going out of the room for a short period of time. He gets worried at the thought that his mum might go out, and he's unable to function when, most children, you can jolly them out of it when a babysitter comes, and there's a huge impact. So let's see what his mum says about it. He gets frantic if left on his own in a room. He follows me from room to room. I feel like a prisoner at times with him as my warder. He is reluctant to let me go to the bathroom by myself, waiting outside the door until I come out. He won't stay over with his dad. We're divorced and I've remarried. It's not easy to get him to go to nursery school in the mornings. He's, even with a good babysitter who he's known all his life, he gets very upset if I go out with my new husband. He won't go to bed or fall asleep until I'm back. There's hardly a day goes by without his getting really upset, sometimes to the point of tears, sometimes shouting and screaming. If I refuse to stay in or get cross with his clinginess, it makes things worse. I'll need to spend ages reassuring that I'm not going to leave him. He really mucks everything up. He really shouldn't need to cling like this now. I could understand it when he was a baby, but he's almost 4 and should soon be going to school. It first started, forever. He's always been a mummy's boy. At first I rather liked it, but now for the last couple of years I've wished he was more independent and didn't rely on me so much. They're certainly interfering with mine, but seriously, I'm sure they're really interfering with his life too. He can't stay with his dad, and it can't be pleasant worrying so much about these completely unnecessary things like my being in a car accident or his being kidnapped or my running away and abandoning him. He really has nothing to be afraid of, but it couldn't have helped that when he was little, he saw so many rows between me and his dad, so his mum obviously feels a bit wretched and guilty, and many of them were violent. We spent a while in a battered wives shelter but plenty of my friends went through similar things and their children haven't turned out cleanly like Bill. So I mostly think it's him. Has the mother done anything about it? Well, the teachers at his nursery school are really helpful when he gets upset about being left there. I don't know what I would do if I didn't at least get a couple of mornings for myself. So what do we think? It's tricky, isn't it? This is a little boy of 3. He's obviously had quite a tough start in life. And actually he has had some things to be really quite anxious about. And I can see if his mum was being hit in front of him, actually he might feel very responsible for her safety or what might be happening to her. So we had a system where we were rating independently as raters, but if there was a case like this where you think, actually that's right on the cusp, we would flag them, and we met every week as a group of raters where we brought all our difficult cases, and it was partly about us not going off on tangents and rating in our own way. It was part of us keeping the rating as consistent as possible. But it was also really good to discuss these tricky cases. And sometimes we argued each other completely round the other way. So we still disagreed, but we disagreed from different perspectives after a debate about it.
Okay, so I'm going to talk a bit about the development phase of the survey and talk you through a number of steps that we did before actually launching fieldwork in January 2017. So this is effectively what I'm going to be talking about here. So from there you can see that NatCen, ONS and Youth in Mind were awarded the contract to run the survey in September 2015, and we ended up publishing three years later in November 2018. So we had 3 years within which to design, develop and conduct the fieldwork and then analyse the findings. So I'm going to talk through those middle bits bit by bit. So first of all, we conducted a methodological pilot in November 2015. Our original plan was to, for interviewers to go into the household, collect various bits of information outside of the DORBA, which Tamsin has just gone through, and then the DORBA itself was going to be conducted online. So the idea being that interviewers would go into the household, open up the online DORBA with them, they would run through the DORBA there and then, and data would be transmitted straight back to Tamsin's team, which would then be rated and then passed back to us. But there was a little bit of a concern because obviously this would be the first time that it would have been conducted online. In the 1999 and 2004 survey, the DORBA was administered by interviewers. So we ran this methodological pilot. Up there's a dongle. Effectively, we were going to assess whether we could use dongles in participants' homes and connect to the internet that way. So the fieldwork was conducted by NatCen and ONS, and 34 interviewers carried out the fieldwork between November and December 2015. And the objectives were really to see whether coverage of internet across England was sufficient enough in order to conduct DORBA online. As you would have got from Tamsin, it's a big programme that would have to be loaded. It's not just a kind of easy website. It would have to be a really good internet connection in participants' homes. So we selected a range of different geographical areas, looking at rural, urban areas where we knew there'd be good Wi-Fi connection or good 3G, 4G connection, and areas where it might not be so good. And we wanted to test the speed of connection in those areas and see how well the performance of the DORBA tool using dongles on interviewers' laptops would, whether that would work and whether this was going to be a feasible option. So effectively, we asked our 34 interviewers to connect to the internet using a dongle. This was outside of a participant's home. This was just in their own home. So they were selected, again, across, as I mentioned, across England. And once they were connected, we asked them to complete the DORBA twice. So once in the morning, once later in the evening. Record the time that it took to go through the DORBA, and then complete a short form and return that to the office. Effectively, we've got a report on this. The conclusion of it is that the time that was taken to complete the DORBA was extremely variable. In many cases, the interviewers had to give up, or they lost connection and they had to restart. It took a lot longer than going through the DORBA, which Tamsin just did here, with good Wi-Fi connection in certain areas. And ultimately, we agreed that online DORBA collection was not going to be possible. So we had to adapt our approach, and ONS took on the task of programming the DORBA into a CAPI program, so computer-assisted personal interviews. You were able to base it on the 2004 DORBA, but as Tamsin mentioned, it has been refined over time. So there was a substantial amount of work that you undertook to get it into CAPI. But that effectively was the first part of the study, methodological pilot. So already our approach was changing a little bit. We then conducted a public consultation on the content of the survey. And this was opened in November 2015 and was open for around 6 weeks. And the objectives of this was to find out which existing topic areas from the 1999 and 2004 survey we should continue to include, whether there were new questions or topic areas that should be included in the 2017 survey, and also where new areas were suggested, which areas should they replace in the suggested structure from the 2004 survey. So the consultation was launched by NHS Digital, and it was launched in November, closed in January, and we also had a group discussion with 10 young people aged 16 to 24 who we identified via a mental health network who had a strong interest in mental health, and we consulted them on what they thought the survey should include. So we found that more than 600 people and organisations viewed the online consultation. And of these, just over a third submitted responses with their ideas on what I just said about what should be included, what should be excluded. It was via a series of semi-structured questions, but also some open questions at the end about any other ideas that people might have. And we got a really good range of respondents who completed the consultation, including academic, clinical, public, private and the voluntary sector, and we did also get some members of the public who obviously have an interest in mental health, giving us their views on what we should do. And ultimately the findings from that was that 47 new topics were suggested by respondents, and by far the most popular topic for inclusion were online activity and its impact on children and young people's mental health. And cyberbullying was the second most popular suggestion after that. There were also some topic areas which respondents suggested should be expanded a little bit. And in terms of removing content, there were 42 separate topics or questions that were suggested to be removed. And the most commonly cited or suggested one for that was smoking, drinking and drug use questions, which is included in the self-completion child questionnaire. Saying that, most commonly, most people didn't want anything to be removed at all from the survey, but we had to balance out the questionnaire content a little bit. Ultimately, the findings from that is that up here, I've obviously excluded the DORBA and SDQ, which is obviously the central part of the interview. So these are the other topics around it, but these are the topics that we included in the final questionnaire. Anything in red there is either a new set of questions that were included for the 2017 survey or ones that were slightly adapted. So, for example, school exclusions and truancy have been collected in the 1999 and 2004 surveys, but they were adapted a little bit and expanded on for the 2017 survey. Linked to that, with the suggestion of the new topics of effectively social media and cyberbullying, between February and August, we conducted 2 different studies. So we conducted a cognitive testing study, and then also, as Tim mentioned earlier, we conducted a full-scale pilot. So if I mention the cognitive testing study first of all, So the method for this was that we recruited participants via a recruitment agency. Interviews were carried out in South East London, East Sussex and Hampshire. And we interviewed 12 parents of 11 to 16-year-olds, and they had a 30-minute interview, and also 20 young people aged 11 to 19 whose interviews were quite a bit longer. The testing explored these key areas. So first of all, we wanted feedback on the survey documents. Some of the survey documents. The three that we asked for their views on were advance letters, information leaflets, and also the data linkage consent form. Also, feedback on their willingness to partake in such a survey. The ability to answer the new survey questions, including the new modules on social media and cyberbullying, and also they explored sensitivity around some of the other questions in the modules that were on that previous slide. In summary, there are a lot of findings from this report, so I've kind of condensed them here into a couple of slides, but ultimately we were able to refine our survey documentation. We got really useful feedback on some aspects of what we included in there, such as how easy it is to opt out of the survey and how much information we're providing in advance about the study. Social media questions, we developed some completely new questions for that module, but also took some from a survey carried out by Ofcom. And for the cyberbullying questions, we adapted a series of these that were included in the British Crime Survey, the Millennium Cohort Study, and also some versions of a bullying questionnaire. So effectively what our cognitive testing team did with those questions, but they simplified the language, the length of the response options were shortened, and also the time frames reduced, so that we adapted them for our 11 to 19-year-olds who we were going to be interviewing. If I move on to the DressRehearsal Study, so this took place in June 2016, and the main aims of this were to test the administrative procedures, the interviewer's perceptions of the survey, again, some of the survey materials that were going to be used in field. We got feedback on order and flow of the interview and how that felt in the household, and also the interview length. Obviously, by including new modules of questions and having tinkered around a little bit with some other modules of questions, we needed to make sure that we were getting an interview length that was going to be acceptable to the participant, and also within the, with what our anticipations were as well. So, as I mentioned, it was conducted in June 2016. For this survey, we selected randomly from participants who had taken part in the Health Survey for England in 2015 and consented to recontact. And similarly, at this point, Scotland was going to be part of this survey. As Tim mentioned earlier, that didn't quite happen in the end, but at the dress rehearsal stage, it was we were assuming Scotland was going to take part. And so for that dress rehearsal, we followed up some participants who'd participated in the Scottish Health Survey in 2015. So it was quite a large-scale dress rehearsal. We selected 440 addresses, and these were issued to interviewers. And just to mention, the survey in the field was actually called the National Study of Health and Wellbeing, Children and Young People, just because we didn't want the focus to be primarily on mental health. So that's what we called it in field. So the advance letters, this is just to show an example of the advance letter. We had two different types. One was sent to the 2 to 16-year-olds, sent to the parent or the guardian, and for 17 to 19-year-olds, we sent letters out directly to the 17 to 19-year-old themselves. And we got really useful feedback from interviewers about how well received those advance letters were. You'll see at the bottom there's a £10 post office voucher, so we wanted to assess how well those were received as well. And got good feedback on that. And also information leaflets. This is just examples of what we use. So you'll see that there are 3 different information leaflets. One that was information for children, information for parents and carers, and then also one for information for the 17 to 19-year-olds themselves. So the language within those information leaflets differed a little bit, and the level of detail that we went into also varied. But yeah, again, we got feedback from our interviewers about how well they were received by participants in the field. The length, order and the flow of the interview, we were really pleased. We found that actually what we'd developed was broadly in line with what we were hoping for. We were able to get specific feedback on some of the questions, so we were able to update some of the CAPI wording, including some of the interviewer instructions. And we also got some really useful briefing points for the main stage, such as there were going to be some really long interviews, and interviewers needed to be prepared for that. So you might have some, have you got some, a little bit of information on timings later. We also covered the DORBA in more depth in the briefings themselves. In the dress rehearsal, interviewers reported back that some of the questions as they were going through them seemed a little bit repetitive at some points, but there's always a reason behind it. And actually the subtlety of the wording that Tamsin has just illustrated so nicely actually makes quite a big difference in how a particular case is going to be reviewed. So we went into more depth with interviewers about the DORBA in the briefings, just so that they're fully aware as to why we're asking what we're asking. Also, we got feedback that in field there were some participants that got upset or got, it raised questions that were quite challenging or quite emotional, and so we had a part of the briefing for the main stage on how to deal with those sorts of situations and how to use the study documentation that interviewers were supplied with most effectively. Points of, if the participant needed to have a break, then that was absolutely fine. I think the longest interview in the dress rehearsal was over 4 hours long, so these were sometimes intense interviews. And also really nicely from that, we got a recorded video message from Robert Goodman that we used for the main stage. And in that, Robert he talked about the DORBA and why it was so important, and just thinking there were a few things that he particularly pointed out. So the in-depth, open-ended responses, where we wanted interviewers to probe for as much information as possible if something did come up in conversation. He highlighted how useful that information is and how interviewers should deal with those sorts of situations. The types of questions that they should ask, and also he, just really encouraging motivational message. So there were some nice things that we were able to pull out from the dress rehearsal to then use at the main stage. The other big thing from the dress rehearsal was the teacher survey. So this is a brief overview of how the teacher survey was conducted in field. So effectively, the interviewer would ask the parent for consent for us to contact a child. To contact a child's teacher. The child themselves would then choose a specific teacher for us to make contact with. We then gave the child to give to the teacher a contact card to tell the teacher we're going to be in touch, it's about this survey, this is what we've done so far, and this is what we're going to be contacting you about. And then the interviewer would then collect the name of the teacher, the school name and the email address of either the teacher or invariably teachers won't have direct email addresses, so we'd have to get some sort of general admin or office email address that we'd need to contact. We'd extract that information from the CAPI. We then clean that information and then sent out a questionnaire, which in the dress rehearsal was an online questionnaire, which Tamsin mentioned earlier. We found probably wasn't going to be sufficient. So anyway, this is the This is the contact card that we asked children to give to their teachers. So there's a place on there to give the child's name and the parent's name. And the findings from the teacher survey, effectively we looked at three key stages. The first one was about gaining consent, gaining participant consent to the teacher survey. The second one was actually inviting the teachers to participate. And the third one was getting them to complete the online questionnaire. This was all conducted in July 2016, I should just mention. So at the consent stage, if I go through each of those stages, consent stage, we actually found that we had really good consent rates from participants in the household. So these were, participants who were absolutely fine for us to contact their teacher. We did, however, have a couple of points where we expanded the briefing content for interviewers about the importance of the teachers, as Tamsin has talked about, how important that perspective is, getting from the teachers. And also, we work closely with Robert about making sure interviewers are given the right training and the right tools to use when they're in the household. So at consent stage, we did pretty well. Things fell down a little bit at the invitation stage. Ultimately, we needed to get better contact details. So we needed our interviewers to input better contact details. We found that they were often insufficient, so we weren't able to send out an email at all, or that we got emails bouncing back. So there were four main things that we did for this part of the process. Interview a briefing point about the importance of getting a correct email address and the correct teacher's name. Also within the CAPI, we also improved the validation rules around collecting an email address. The second thing was EduBase, and so this is effectively a register of all schools in England that is, you'll probably all know, but kept by the Department for Education, and we inputted that into the CAPI as a lookup file, so interviewers could look it up in the database, and we would get head teacher name, and we get correct school address. Email address isn't in there, so we still had an issue around email addresses, but this was a vast improvement once we got EduBase in there. As I mentioned, CAPI input improvements as well. Around validation rules, collecting email addresses, and also sample cleaning. We realised that we had to invest a lot more time in sample cleaning at our end in the office. We couldn't send out letters to Miss X in Flamingo class at such and such a school. So we realised at that point we needed to be spending a lot of time at main stage cleaning the sample that was collected. And then at the participant stage, ultimately, the teacher response rate was lower than what we anticipated. We had a challenge of getting teachers' attention. So there, emails coming through to teachers, it's how can we get our email to stand out and, be effective. And with that, we were able to analyse the response rate, but also other metrics such as the percentage of emails that were opened and the percentage of links that were then clicked on, and pulled all that together and introduced a number of measures to improve that part of the process. So just to pull out some examples, for the main stage, we got a supporting statement and logos from the Department for Education and the Department of Health, which we put at the top of emails and in the letters themselves, just to emphasise that this is an important study, and please, as it says at the end, your response will help us make a difference. We also then sent out head teacher letters. Some of the feedback was that participants were worried that if they gave a teacher's direct email address, how would that be perceived within the school? So we decided to invest in sending out a letter to the head teacher telling them that we've invited your teacher in your school to participate in the study and this is why. And also the main thing that came out of it is an online responses weren't going to work, we introduced a paper questionnaire, as Tamsin mentioned. So we introduced one at the very start, and then if we hadn't heard back within a few weeks, we'd send out a second paper questionnaire, as well as the online option. And interestingly, with that, we found that 2/3 of teachers participated using the paper questionnaire rather than the online questionnaire, which I think is quite a, so our response rate at main stage greatly improved, which obviously is fundamental to the data that we then sent to Tamsin and her team of raters to then to look at in more detail. And the final thing is that we developed an optimal email reminder strategy. So if we weren't getting emails back or questionnaires back, then we sent out up to 3 reminders over the course of 3 or 4 weeks at certain times of day, trying to, target teachers when they might be less busy. Not that they ever really seem to be, but trying to work out what would be best for a teacher. And that's all produced in a separate report. That was a bit of a whistle-stop tour through all the design and the development stage. But at this point, after that, we finished all of that in August 2016, and we then had a few months to turn this all around within the ethics committee. So obviously all the feedback that we'd got at various stages, particularly around participant-facing documents, had to go to ethics. And fortunately, we also got approval to use the MIDAS dataset in time for the main stage. As I mentioned, for the dress rehearsal, we did have to use a different sampling frame, so we weren't able to assess response rates as much as what we could have done at that point, but we got it in time for the main stage. And that's going to be what Salah is going to be talking about